Can anyone hear me now? Perfect. Okay. I'm calling in from my phone, so hopefully the connection stays all right. Sorry about the delay. Let me just close some windows here. All right. So for critical care new conference today, we're going to be talking about acute hepatitis, which is something that we've been seeing a lot of over the past couple of months. It's very near and dear to all of our hearts, I think, at this point. I worked with Dr. Abu Saif, who helped me out with this presentation. And so here we go. So first off, we're just going to congratulate our first years for completing a week of the triage phone and my obligatory Hamilton reference here. And only 151-ish weeks to go. So kind of a brief outline of what we're going to talk about today. We're going to define some key terms, give you some background on acute hepatitis, figure out some of the major causes, or at least walk through a couple of examples. With each one, I'll try to give some clinical pearls about what we might expect to see clinically, and then some treatment strategies. And then at the very end, although it's somewhat out of the scope of acute hepatitis, I think it's reasonable to talk about acute liver failure, because in critical care, that's probably what we're going to be seeing, not kind of the mild acute hepatitis. But before we go any further, a somewhat hypothetical scenario. You're holding the triage phone. ATMO gives you a call. Hi, Doc. It's Wanda from ATMO. I have a physician from Mid-McLaren Bay, Beaumont, St. John, Providence City on the line. Wants to transfer a patient. U of M was happy to accept, but they had no beds. Last known vitals are a PEEP of. The next best step in management is, and we'll kind of do this board's review style and go through each of the options and kind of talk about why it's right or wrong. So first option, accept the patient and hang up. Obviously, that's a big no-no. It's pretty rude to begin with, and also we have to actually talk to the transferring physician. So option A is wrong. In option B, you're gonna tell Wanda that you're busy and that she should talk to your staff. Also a no-no. If anything, you're picking up the phone, meaning you're probably not all that busy. And secondly, you can always tell ATMO to give you a call back in a couple of minutes if you're doing something urgently, like coding a patient. That's definitely appropriate. So option B is not a right answer. Option C, you're going to politely redirect Wanda to pause, give you some basic patient information like a name and possibly an MRN. You're going to ask to speak with the transferring physician, and then most likely accept the patient. That sounds pretty reasonable to me. Let's see what option D holds. Why bother? Zone out, place a hepatology consult, and then the whole order set with all the labs and all the meds that you know are coming your way. You're going to talk to charge nurse, get a Blakemore on standby, and all the things that we're used to doing. And as I soon discovered while I was researching for this topic, there's a lot of nuances in dealing with sick liver disease patients. And so putting the whole order set in from the get-go is not the best option. So we're going to go with C. So some key terms. So what is the difference between acute hepatitis and acute liver failure? So acute hepatitis is generally the more mild condition. It refers to any acute condition that causes any sort of inflammation or injury to your hepatocytes, generally characterized by either having no symptoms at all, or a transaminitis. You can have some mild LFT abnormalities like an alk phos elevation, some jaundice, and kind of present in any combination of these things as an example. Acute liver failure has some pretty specific criteria. I went by the AASLD criteria, which is the American Association for the Study of Liver Diseases. So their criteria are firstly coagulation abnormality, which for all intents and purposes is usually going to be an INR of greater than or equal to 1.5. Any degree of encephalopathy. The patient can't have any prior history of cirrhosis, which is a little bit confusing because they actually do accept Certain cases, if they have prior cirrhosis, like Wilson's disease or vertical transmission of Hep B, for example. So that's kind of a generalization that there are some exceptions to. The fact that it's acute means kind of they made this cutoff of 26 weeks of the duration of the illness or less. Longer than 26 weeks is going to be chronic. And then you're going to see a lot of the same types of lab abnormalities. They could be just as mild, they could be more severe. And as you can see in the diagram here, there's actually a whole bunch of different organ systems that are potentially affected by acute liver failure. The two things that I highlighted here are your coagulopathy and your hepatic encephalopathy, because those are, part of your criteria for acute liver failure. But as we know from these patients that come into us from the ER or from outside hospitals, people with acute liver failure are often in multi-system organ failure. And this kind of showcases why that's the case. Just a couple of points on cirrhosis, again, outside the scope of my talk on acute hepatitis, but since the distinction between acute liver failure and cirrhosis is in the definition, I thought it was probably a good idea to talk about some major differences. Cirrhosis obviously being a progressive fibrosis of the liver, really, really strongly suggested by a good history. Physical exam, there's a lot of overlap between all these conditions. Hepatomegaly certainly is not specific. A couple of these things, ascites, jaundice, you can get that with a lot of different spots along the spectrum here. Splenomegaly, I think, is a little bit more common in cirrhosis just because it usually is subsequent to hepatomegaly and kind of backwards pressure gradients and things like that. And so it usually happens later in a course. So something like chronic liver failure or cirrhosis. Spider angiomata, caput medusae, kind of same thing. They don't usually happen in the acute setting. So those are a little bit more common in your cirrhotics. There's labs that can help you at least think about making the diagnosis. There's no lab that's going to tell you cirrhosis or no cirrhosis. And in general, the key here is most of your lab abnormalities will get more severe as the cirrhosis progresses and becomes more advanced. So for example, your hyponatremia gets more severe. You can develop HRS. I kind of made up hypercreatininemia just to go along with everything else, but I think you get the picture. Thrombocytopenia, same thing. Usually in cirrhosis, it's a sequela of splenomegaly and sequestration of your platelets, and so it usually happens later in the course. Imaging, pretty much everybody who walks through our emergency room tends to have a CAT scan of some form, and it can certainly suggest cirrhosis, but it's not the gold standard. And the big example to keep in mind is that somebody with massively necrotic liver can appear on CAT scan as nodular and cirrhotic appearing, when in fact it's actually regenerating, or in the regenerative phase at least. So you can be fooled just looking at CT alone, which is typically why in the patients that we see and we're worried about cirrhosis, we're also ordering an ultrasound, sometimes an MRI. What we would hope to see, to kind of lead us towards cirrhosis on an ultrasound is you're going to see increased echogenicity, nodularity, that sort of thing. Elastography is something that we don't do very commonly, but just kind of looks at stiffness of the liver tissue. Some other features that can be seen on ultrasound or MR or even CT sometimes are portal vein thrombosis, or a reversal in your portal vein flow, kind of suggestive of portal hypertension. Lastly, I'll say that biopsy of the liver may be necessary. Sometimes you can make a diagnosis without it, but it's something that you'll see the hepatologist recommend from time to time. All right, so more about some background on acute hepatitis, acute liver failure. There is a pretty big disconnect between the US, and I'll kind of include UK and Germany based on this map, and pretty much the rest of the world in terms of what causes acute liver failure and acute hepatitis. It's a large percentage, or a large percentage of the cases here are caused by acetaminophen toxicity or overdose. And really, in other parts of the world, in most other parts of the world, it's some sort of infectious etiology, whether it's viral or something else. And I have a slide on some of the other examples in just a little bit. But I think it's a pretty big disconnect, and it's worth mentioning because depending on where you're practicing and where in the world you are, you have to think about different things. I kind of mentioned this before, the distinction between acute and chronic, around the 6-month or 26-week mark. And I'll come back to this next point, but the etiology behind, what's causing that acute injury to your hepatocytes is really going to determine what your prognosis is and how you're going to manage the patient in front of you. There's a couple of broad categories. I'll touch on some of these or most of them. I'm not going to do an exhaustive list. If you look at the up-to-date chart on liver failure or acute hepatitis, it doesn't even fit on 1 or 2 slides. It's huge. And so I will talk about some of these things and kind of broad strokes. Also, generally, again, these are not absolutes, but they're pretty good patterns to know. There's 3 main ways that you can think about your biomarkers, your LFTs. So the first is kind of separated into 2 categories. So hepatocellular injury can be separated into either damage to your hepatocytes or cholestasis. And you'll see us talk about this, your patient has a cholestatic pattern on his LFTs, that sort of thing. So in terms of hepatocyte damage, I make this distinction between markedly elevated transaminases and just kind of a little elevated. And this is just a kind of a made up number, although it seems to be fairly accurate. If it's over 5 times your upper limit of normal or below that. When you're above 5 times upper limit of normal, these are going to be your things like your drug-induced liver injury, shock liver, and acute biliary obstruction. The main difference between those things is your biliary obstruction is going to have a high bili, and the other ones generally have a normal or maybe a mildly elevated bili. And then in your other transaminitis picture where it's elevated but not so markedly elevated, that's going to be pretty much everything else. Your autoimmune, hemochromatosis, I just kind of listed a couple examples here, but we'll get into some specifics in just a bit. Cholestasis, your ALT to alk-phos ratio is going to be less than 2. And some examples of conditions that cause cholestasis, choledocholithiasis, primary biliary cirrhosis, or sclerosing cholangitis. Malignancies can do it. And so these are kind of, again, broad patterns that we'll come back to that help us figure out what our differential is for why somebody has acute hepatitis. You'll also hear us talk about synthetic dysfunction as a way of commenting on how severe somebody's liver injury is. So I think it's important to talk about. I will talk about vitamin K factors in a little bit, but obviously a lot of these factors are made in the liver. So if you have liver dysfunction, you're not going to be able to produce all your factors. Albumin also synthesized in the liver, and so people with kind of progressive liver disease will also have a progressive hypoalbuminemia. Kind of makes sense. And then the last category is your metabolism or catabolism. So with bilirubin, keep in mind, bilirubin is kind of the breakdown of your heme-containing pigments, your proteins and other molecules. And so if you have any sort of liver dysfunction, you can get an elevated bilirubin because that's where kind of the metabolism and excretion happens. Ammonia, I'll talk about kind of the mechanisms of metabolism of ammonia in a couple of slides. But suffice to say, obviously, we're all well familiar with ammonia or hyperammonemia and liver dysfunction. And again, I'll talk a little bit more about that as well. All right, so some specific examples of acute hepatitis and what we do about them. So first, I'll start off with infectious because it's kind of the most straightforward in that once you figure out what the infection is, you can either do something about it or not do something about it. And then I like to separate, your hepatotropic viral hepatitis viruses, I don't know, which are your A, B, C, D, and E. And then everything else is non-hepatotropic. With your hepatotropic viruses, the incidence of hepatitis A and B really dropped in the 90s after the advent of the vaccines for those respective viruses. Although I will say there is a little bit of a surge now with like increasing IV drug use and persistent homelessness and that sort of thing. Especially in certain parts of the world you get foodborne transmission to think about for hepatitis A. And so again, still good to think about. Hepatitis C, interestingly, doesn't really cause acute hepatitis by itself unless there's coincident hepatitis B, and I think that's also true for hepatitis D as well. But they have to be on your differential, and checking your hepatitis serology is going to be a reflex for that exact reason. There's conservative management for a lot of these things. Hepatitis B, there's some evidence that lamivudine may help, your antiviral, but unclear. HSV, CMV, EBV, all these other things, they are known to cause acute hepatitis, so it's good to think about. And if you don't have it on your differential, you're potentially going to miss it. And I will just mention, again, we don't see a ton of it here, but just liver abscesses and things like that, liver flukes, you'll see them in different parts of the world, and you'll get somebody coming from another country or recently came from abroad. These are things that you got to think about. Autoimmune hepatitis is another, they're all kind of somewhat rare. We don't know exactly why it happens. We think there's probably some combination of a genetic predisposition and then on top of that, some environmental trigger. Pathophysiologically, it's a chronic inflammation, we think secondary from circulating autoantibodies. And there's a large list of the antibodies that can do it. So your ANA, ANCA, anti-mitochondrial antibody. There's a whole bunch of them that could do it. And in terms of clinical presentation, as with a lot of these kind of subtypes or etiologies, you can really see a full spectrum from somebody who's asymptomatic for a really long time to somebody who's in decompensated cirrhosis. I think I saw one statistic that at the time of diagnosis of autoimmune hepatitis, 30% of patients were already cirrhotic, which is crazy to me. But it's because they are so asymptomatic for such a long period of time that it flies under the radar. Another thing to keep in mind is oftentimes people with autoimmune hepatitis can also have a hypergammaglobulinemia, specifically an IgG, but not everybody does. Patients are also at increased risk of hepatocellular carcinoma, and even more so the ones who are already cirrhotic. Treatment-wise, it's, really the first line is your steroids. You're going to give prednisone 60 milligrams daily for at least several weeks and start tapering. Steroid-sparing agent is thioprin and 6 milligrams of purine. And then, if all else fails, that's when you think about transplant. Primary sclerosing cholangitis, it's a progressive fibrosis of mainly your large biliary tree ducts. There is an association with ulcerative colitis. Again, we don't really know why it occurs. We just know that there's some association there. Your symptoms can be really variable, just like a lot of the things that we're talking about. Oftentimes people have kind of non-specific symptoms like fatigue and pruritus. You know what I mean. Lab-wise, you'll get that cholestatic picture that we talked about. Imaging can be pretty helpful. You'll see an abnormal biliary tree with usually like short strictures and then kind of areas of dilation in between. Anytime you see like long strictures, that's when you start thinking about like malignancy or cholangiocarcinoma. But that's really subtle. And like I looked at all the examples and I couldn't really figure out what they're talking about. I have a picture and we can see if you guys are better at reading this than I am. Treatment-wise, the traditional treatment used to be surgery, so some sort of biliary enteric, connection there where things could drain, plus or minus stents. That's fallen a little bit out of favor because the outcomes with transplant are improving, and so the trend has been to just refer early to transplant. And again, if you don't think about transplant early, you might miss your window. Yeah, here we go. So hopefully this projects on the Zoom, but what I'm looking at in particular is like strictures here, if you guys can hopefully see my mouse, and then you have like areas of dilation, kind of stricture here, area of dilation. I think that's what I'm looking at, but it's pretty subtle. And if you just showed me this picture, I may or may not be able to pick it out. Primary biliary cholangitis, or as I know it, cirrhosis, is a similar but slightly different mechanism. It's usually small bile ducts that get affected, and it's a T-cell mediated response. Again, we don't quite know why it happens. There's probably some sort of association with other autoimmune conditions. A couple examples I listed here, although this is not by any means an exhaustive list. Symptoms, again, kind of the same things. There are cutaneous features that you can sometimes see, like your xanthomas and things like that, because one of the features that you might see is a hypercholesterolemia. And so that's one of the things that you check on your labs. Again, a cholestatic picture, you can get your antibody tests. The anti-mitochondrial antibody titer greater than 1 to 40 is one of the diagnostic criteria, so that's something to keep an eye out for. And then treatment-wise, your ursodeoxycholic acid is your first-line treatment, and there's people who are on it for years, as long as you tolerate it okay. And then, you think about steroids and then transplant in refractory cases. I actually just saw somebody in the Bronx who's on this for primary biliary cirrhosis. Histopathologically, they do look a little bit different. I'm not great at looking at these, but I think I can convince myself that in primary sclerosing cholangitis, it's more of like an infiltrative and fibrosing process, and the bile duct is still quite patent, because remember, it's a large bile duct process, but then you just get all this scarring around it. And then in primary biliary cirrhosis or cholangitis, there's a lot of lymphocyte infiltration, and your bile duct, which is small to begin with, kind of gets closed up, which helps to explain some of the differences. Other things that can cause acute hepatitis are your drugs and toxins. These are, again, just a couple of examples that we might see a little bit more commonly. I'm not going to go through the exhaustive list. Again, the sub-page on UpToDate that talks about DILI, for example, the chart is like, you have to like zoom all the way out just to get the whole thing in, and then it's unreadable. But there's a lot of different things that can do it. I think the two things that I talk about, firstly, is just alcoholic hepatitis. And again, here there's a spectrum. You can be asymptomatic, you can have alcoholic hepatitis, fatty liver disease, and then obviously cirrhosis being the endpoint there. From what I can tell, the biggest risk factor for developing alcoholic hepatitis is drinking at least 100 grams of alcohol daily for at least 20 years. I think it also depends on, there's probably some genetic predispositions, what other toxins you're ingesting. For example, if you use acetaminophen all the time, you're going to be at increased risk of developing hepatitis, which makes sense. And so this is kind of just a number that I found, but it's not the end all be all. Your symptoms can range from somebody being asymptomatic to having kind of these mild symptoms, some jaundice, right upper quadrant pain. Sometimes you can develop ascites even without having the cirrhosis. On your labs, I think we all learned in medical school your AST to ALT ratio of 2 to 1. And then one of the general rules of thumb here is in alcoholic hepatitis, your transaminases are really not generally going to be above 500. If they're above 500, that's when you really got to think, is there something else going on? Is there a co-ingestion? Did they overdose on acetaminophen, for example, or something else? You can have a high bilirubin, although it's not always the case. And again, your clinical suspicion based on your history and all that other stuff is going to help you quite a bit, rather than just looking for a diagnosis via lab work itself. Treatment-wise, your mainstay is going to be conservative management. You want to resuscitate the patient if they need it. Obviously, these patients may go into withdrawal. You want to treat the withdrawal if necessary, and then you want to do alcohol cessation counseling as kind of their long-term treatment there. Mild to moderate cases, that's really all you need to do. Severe cases, which is defined as your MADRS, discriminant function above 32, and I put the calculator here. It's 4.6 times your prothrombin time minus your control prothrombin time, that whole quantity plus your bilirubin. So above 32 signifying kind of a worse prognosis, and so that's when we start thinking about steroids. Prednisolone here, orally anyways, because of the fact that prednisone needs to be converted to the active metabolite prednisolone in the liver. So if somebody is in acute hepatitis, that's probably not the best idea. Or if they can't tolerate PO for whatever reason, you could just give methylpred 32. This is something that they do for like at least 28 days, and then like a 1 to 2 week taper after that point. And so this is generally the patient you want to try to have good follow-up with, after they leave the hospital, assuming they're going to be out of the hospital. Acetaminophen toxicity, like I said, it's much more common here than in a lot of other places. I saw a statistic in one study that said 50% of acute liver failure in the U.S. is secondary to acetaminophen toxicity, and 20% of our transplants here are from acetaminophen overdoses. So this is nothing to laugh at. This happens very frequently, and it's serious, and it should be taken seriously. I thought it probably would make sense to talk a little bit about the mechanism, because that helps me think about why things happen. So in general, when you take your acetaminophen at a normal, regular dose, most of your metabolism happens in the liver through one of these top two pathways. So it gets conjugated into these non-toxic forms at the top here. A very small amount does leak into your cytochrome P450 pathway into this fairly toxic metabolite NAPQI. Toxic because it generates a lot of free radicals, oxidative stress, and causes hepatic necrosis. But the good news is, in small amounts, your liver can handle it. Uses glutathione, which is naturally stored in the liver, and it gets further metabolized into non-toxic metabolites. So that's great. What happens in overdoses is these top pathways get overwhelmed and saturated. So a lot more is getting shunted down this pathway. You get a whole lot more generation of NAPQI, and then your glutathione stores get depleted, and then you're not in good shape because now you have a whole bunch of toxic metabolite hanging around. I guess I can just talk about this now. So NAC, the way that the mechanism by which it helps is it helps to restore some of your glutathione stores. And so it allows the liver to continue to metabolize your toxic metabolites. Your symptoms, as with everything, can really range from very mild, nausea, vomiting type stuff to very severe, multi-system organ failure type pictures. Your transaminases, like I said, are going to be really elevated. And when I say, greater than 5 times the upper limit of normal, oftentimes you get calls from other hospitals saying, hey, this person's transaminases are above the level of our assay. It's going to be in like the 5, 6, 7,000s. You generally will have a normal bilirubin, but not always. And when we think about treatment, I make this distinction here about early, consideration of activated charcoal. Most of the time somebody comes to the hospital, and especially by the time they come to the ICU, they've kind of already missed a window. It's really like the 2 to 4 hour range after ingestion. So for our purposes, that's generally not going to be our go-to. Although if you're lucky enough, it is a good treatment. NAC is obviously the gold standard here. And I kind of talked about how it works. How do we know when to give it, when it's appropriate to give it? And that's what this graph here helps us figure out. So this is called the RUMAC Matthew nomogram. And basically compares down here your time post-ingestion and your acetaminophen serum concentrations up here, with the thought being when they did the initial studies, the people who seemed to get the most benefit were up at this range here, so at least a serum concentration of 150 at the 4-hour mark. And then I think they did like 16 hours, and it was kind of near the 20 milligrams per liter mark. And so they kind of extrapolated this line. So if your patient has a acetaminophen concentration at a certain post-ingestion time and you are above this line, that's when you're supposed to give the NAC. Below this line probably doesn't really help, although who knows. We often come up with the issue, how do we know when to stop the NAC? There's a couple of different formulations that we have here available to us. There's like the 72-hour oral protocol. There's a 20-hour IV protocol. There's not a lot of data that helps us make this decision. In general, I feel like as ICU doctors, we like giving things IV, so that's what we normally do. But the data don't really help us figure out like an actual mechanism by which that happens. So one is better than the other. From what I can tell, and this is what commonly gets thrown around, in the hospital when you're rounding in the unit, is you can stop the NAC when your ALT is less than 1,000. And I would also add when your serum level is undetectable. Typically, your serum level is going to clear way faster than your transaminase elevation, and so your rate limiting step is really going to be your transaminitis. There's other ways to think about it. When you go to the literature, there's people who like factoring in the INR and other factors like that. So I think you just have to pick something and go with it, because as far as I can tell, there's really nothing that says a certain cutoff is better than another. Other causes, so your cardiovascular or vascular causes here. So Budd-Chiari syndrome is your venous outflow tract obstruction. So that's going to be something in your IVC or hepatic veins even. Typically, if Budd-Chiari is the etiology behind somebody's acute liver failure, the only option at that point is a transplant. Sinusoidal obstruction syndrome, also formerly known as veno-occlusive syndrome, kind of happens in some of the smaller vessels, your sinusoids, your terminal venules. You may or may not need transplant. Sometimes just conservative management helps people get by. And then lastly, I would say we actually see this more so than these other causes, congestive hepatopathy. So in our patient population, everybody's got heart disease, or heart and lung disease, whether it's related to pulmonary hypertension and decompensated RV failure, or left-sided heart disease, constrictive pericarditis, valvular heart issues. If you have a backflow, a gradient, pushing backwards into your liver, you're going to get congestive hepatopathy. And the treatment is really just treat the underlying problem. And then the liver hopefully will recover if you've caught it early enough. Wilson's disease, we don't see a ton of it, but we see it, and it's good to know about. It's a disease of copper deposition, specifically the liver not being able to excrete copper. And so just like with everything else, kind of have the full gamut here of ways people can present. The Kaiser-Fleischer rings are the thing that everybody loves testing about on the boards and all that, and so that's something not to miss. But really, it could affect a whole bunch of different organs, and so you have to be mindful of that. Your diagnosis, traditionally, you're looking at your ceruloplasmin levels, your 24-hour urine copper collection. I would say way before those studies come back, a 2-to-1 ratio of bilirubin to alk-phos is going to be highly suggestive of Wilson's disease, plus your history and your physical exam and all that stuff, plus or minus a liver biopsy, which you may need if these studies are incongruent. Treatment is aimed at chelation, so your penicillamine is kind of mainstay. And then there's even a thought process that, after you're out of the acute phase, you can use chelation therapy as a preventative thing. I saw some literature showing that like oral zinc could help prevent some of these issues as well. In severe cases, if chelation alone doesn't work, I would say your next step is plasmapheresis, which is a more efficient way of doing it than hemodialysis. Although you could, I guess, theoretically do dialysis as well. And then again, in refractory cases, you're thinking about transplant. Hemochromatosis, also kind of an overload picture, except it's typically related to excess absorption from your gut, and then deposition into a variety of different organ systems. And so depending on which organ systems are involved, you get lots of different manifestations. Your diagnosis is going to be suggested by high ferritin and a high transferrin saturation. Your gene testing, which obviously is going to be informed by your clinical suspicion, so you have to think about it first. And your treatment is going to mainly be phlebotomy. Just some differences between your hemochromatosis and Wilson's disease. I think I kind of covered all this, but sometimes it helps to see a visual, at least for me. I definitely like this graphic of the hepatocyte, I think, pooping out a copper penny. And then you're never going to fit. So that's great. So, that's a whole lot of information. And again, it was not an exhaustive list. I kind of picked a couple of things that we see commonly and some that we don't see commonly to help you think about, how you might go about evaluating a patient. But I would say your history and physical is going to be the number one most important thing, and you're going to let that guide the rest of your evaluation. In general, if you have a patient in front of you who's got mild LFT abnormalities, you can start with, just kind of some basic studies here and then kind of see where that takes you and then go from there. Again, typically the patients that we're seeing are not as stable. They don't have the mild abnormalities, which is why we have this knee-jerk reaction often to order everything under the sun in that hepatology order set. And I think it's probably okay because our patients are that sick. But again, this is not an exhaustive list, and things that you elicit in your history or physical exam or, collateral, or if, a patient's intubated, you talk to their family members, those things are going to help you figure out, are there other tests that you got to think about? In addition to your labs, your imaging is really going to be helpful. Your abdominal ultrasound plus or minus your Doppler, like I said, CT and MR have a role as well. But I would say CT and ultrasound are more readily accessible to us, so that's what we're a little bit more used to seeing. So last thing that I'm going to talk about here is management of acute liver failure. Again, because this is probably what we're going to see more commonly than the milder acute hepatitis. We kind of poo-poo the idea when we're holding the triage phone, yet another liver patient coming our way. But when you look at the numbers, it actually makes a whole lot of sense to transfer patients with acute liver failure to a center that offers transplant or at least is experienced in taking care of patients with severe liver disease. There is a significant mortality. It was 60% of patients with acute liver failure of any etiology went on to require transplantation or died. So only 40% recovered without anything, crazy going on. And that's a big number. And so, we end up seeing a lot of alcoholic liver disease. And so I think our numbers here, and at least my experience, is a little skewed. But that was kind of humbling to learn about. Some of the, like I said, the hallmark features of acute liver failure is going to be your encephalopathy. And I put a question mark next to lactulose because, again, it's our knee-jerk reaction. Somebody with liver failure and is encephalopathic, we're just going to order the lactulose and rifaximin. And this is one of those key differences between somebody who has decompensated cirrhosis and acute liver failure, because there's really no evidence that either lactulose or rifaximin makes any difference in managing hepatic encephalopathy and acute liver failure. Lactulose, there's a little bit more evidence for it, but it's not convincing, and there's no difference in outcomes. And so a lot of people don't use it routinely. You want to make sure your patient's getting frequent neuro checks, and you're checking your ammonia levels pretty frequently. So the chart here kind of goes through this is a study of like degrees of severity of hyperammonemia. And below 75, these folks, so up here is your, basically hepatic encephalopathy-free patients, and, they did pretty well below ammonia of 75. When you get into the 7,500 or especially over 100 range, that's down here, that's over half your patients are going to develop hepatic encephalopathy. And then it's not in this chart, but in this study, they show in their patient population that ammonia over 2 actually predicted intracranial hypertension, which is bad. So the mechanism of why this happens, there's a lot that we don't know, but just kind of broadly, in normal healthy metabolism with a normal healthy liver, you have generation of ammonia from all these different pathways, your kidneys, your muscles, absorption from your gut. They all get sent to your liver, gets metabolized into urea, and then excreted out your kidneys. When you take that metabolism into urea out of the equation, you now have buildup of ammonia in your venous circulation, and that gets eventually circulated back to your muscle, where it gets converted to glutamine, gets shunted to your brain, where it also gets converted into glutamine in your astrocytes. And then what that will do is actually that causes your cerebral edema, because now your intracellular osmolarity has changed and water follows the gradient, and now your brain is swelling. Your kidneys can compensate to a degree by converting ammonia into ammonium ions, but it's not as efficient and usually can't handle the whole load, which is why people start developing symptoms. I think it's also useful to recognize that there is a grading system for hepatic encephalopathy. We don't commonly see the grade 4 here where somebody's in a coma, but I would say we see the full spectrum of 1, 2, and 3 in the units here. And I would even argue it sure seems like on the floor sometimes, grade 1 or 2 is maybe standard. I don't think we routinely use EEG, and that's something that maybe we could start doing to help differentiate. But I would say, yeah, we see the full range here. A couple of notes. At grade 3 is where it's recommended that you electively intubate patients, both for airway protection, but also because you start thinking about balancing their PCO2 and potentially even having to hyperventilate them. And interestingly, what I also saw was when you're intubating patients with acute liver failure, you really want to have RSI. And so even if the patient's completely out of it and you think it's going to be easy tube, with the tools that we have available to us currently, it may not be the best idea because there's still a chance that they can get hypercapnic, even transiently, and potentially hypotensive transiently, and those are both potentially disastrous. I think of encephalopathy, cerebral edema, and intracranial hypertension in somewhat of a spectrum, and each one is progressively worse than the one before. When patients progress to intracranial hypertension, the mortality is quite high. Here's just a sample algorithm of kind of how one study recommended you manage patients on that spectrum. So kind of, like I mentioned, endotracheal intubation. Once you get to grade 3 or 4, you could consider lactulose, and it kind of has this comment here that efficacy and safety is unproven. So what you'd like to do ideally is prevent cerebral edema. So that's like simple things, keeping the head of the bed up, allowing the patient to hyperventilate and that sort of thing. If you start seeing evidence of intracranial pressure greater than 20 to 25, you have to start doing more things, essentially. That's when you start thinking about your mannitol and your hypertonic saline. And if that fails, then you're doing even more things. The placement of intracranial monitors for your pressure is a little bit controversial because patients tend to get infections and things like that. So anyways, just something to think about. And, we don't think about it routinely, Probably they do it more frequently in the neuro ICU, but it's something worth mentioning. Hemodynamics-wise, so here's an interesting point that I think I knew at some station in life and then forgot. But there's actually a MAP goal of 75 in patients with acute liver failure for a couple of different reasons. One is, again, they tend to be in multi-system organ failure. And you also want to maintain a cerebral perfusion pressure of about 60 to 80, although I've seen 50 to 60 being another goal. But essentially, your MAP above 75 will help to ensure that. What I found was your norepinephrine is going to be preferred over dopamine, even though both of them can certainly augment your MAP, raise it to your goal, and actually both of them increase your hepatic flow. But your dopa also has your alpha effects and causes tachycardia and other things that can sometimes cause more damage. And so your norepi is going to be a little bit more preferred. And then your second line potentially could be your vasopressin if your norepi dose is getting too high. Resuscitation, something that we do very commonly and probably don't need to spend a whole lot of time talking about. But if your patient with acute liver failure needs to be resuscitated, saline or LR, but if they are acidotic, a bicarb if needed as well. Couple quick points about coagulopathy in acute liver failure. So Mike Harrison was a fellow here several years ago, EMIM Critical Care, had this paper called The Misunderstood Coagulopathy of Liver Disease, and basically did a literature review on all the different ways we mistakenly basically just look at the INR when we shouldn't be. So he has this useful chart here, which summarizes a lot of the different factors involved in procoagulation and anticoagulation and fibrinolysis in our bodies. And I'll just call attention to this column here, which shows your liver is responsible for making all these clotting factors and your fibrinogen, also responsible for making your protein CS and Z and your AT3, and also plasminogen. And so you can imagine when somebody's in acute liver failure, it's really complicated. It's a mistake to look at your INR and say, my patient is going to bleed like stink because their INR is 8. Because if you think about it, the INR was developed really to help us assess the efficacy of your vitamin K antagonists like warfarin, and it doesn't give you the whole picture of all these different factors. So what do we do about that? Typically we'll try to replete vitamin K stores, and certainly if you see your INR dropping after a dose or two, you don't have to give the 3 doses, but that's kind of a general guideline. Patients who are coagulopathic end up tending to bleed from their stomachs or their guts. So even if they're not intubated, I would advocate for putting them on some sort of therapy for GI or stress ulcer prophylaxis. A lot of these patients tend to have thrombocytopenias. And so if they're bleeding, we often say transfusion goal of 50 and otherwise down to 10. And then I would say the rest of your transfusion products are going to be really controversial for the main reason that pretty much all of them come with a lot of volume. And kind of paradoxically, if you over-resuscitate somebody in acute liver failure who's bleeding, you can actually increase the flow through the capillary beds and increase bleeding potentially. So I think you have to be really thoughtful about what you're trying to correct. For example, if you just want to give fibrinogen, maybe cryo instead of FFP because it's kind of more concentrated. Yeah.
Do you know if there's any role for PET scans for these patients? Because it seems like when you look at a lot of the PET scans for these patients, they're actually profiling and trying to give them all these profiling stuff.
Correct. Yeah. So for the people on Zoom who couldn't hear, the question was about TEG scans and the fact that people actually seem to be pro-coagulopathic. And that's absolutely right. So that's part of the reason why I think it's a mistake to just say, hey, IR won't do our LP on this patient because the INR is, 8. So let's give them a bunch of FFP. I think that's a mistake for that same exact reason. So we're actually going to harm our patients potentially more than, just fixing a number, which, yeah, you'll fix the number a little bit, but are you helping the patient? Probably not. But that's a good point. And so I think this is the last slide, but there's a lot of back and forth, even among hepatologists, about whether you should give NAC for all comers of acute liver failure. So this is a study that's pretty much widely cited. and it's from over a decade ago, but basically they looked at non-acetaminophen acute liver failure. So, I mean, if you look at their study, there's Budd-Chiari, there's other DILIs, there's shock liver, there's a whole bunch of different causes of liver failure, or acute liver failure, and they randomized people to either acetaminophen, to NAC or placebo, and basically found there was a statistically significant transplant-free survival in patients who got NAC. The caveat being there was a more significant difference when the patient was like early stages of acute liver failure. The main risk associated with NAC, there's this very rare, but it does happen. People can get a hypersensitivity reaction, kind of almost like an anaphylactic type, although it's not IgE mediated. And so we end up giving epi and steroids and all that stuff, and people do fine. So for the most part, when people think about it, we say the risks are worth the benefit, because if they're in acute liver failure, they're probably going to be in ICU. They're going to be well monitored. If they have the reaction, they get the treatment right away, and then you convert to oral and they do just fine. The other thing to think about is the IV NAC tends to come with a large fluid load. So again, if you're worried about over-resuscitating your patient, or if they're already fluid overloaded, for example, just something to think about. That being said, even, like last week, we would talk to hepatology, and 2 different staff would come by on consecutive days, and one would say, give NAC, the other would say, don't give NAC. So I don't think there's a consensus. And again, this study was from 2009, and I didn't really see a whole lot more recent literature in hepatitis. I think a lot of people tend to feel, because the risk-benefit profile is kind of okay, that we tend to give NAC even in shock liver and things like that, unless we see a clear contraindication. So that's all I got. I'm going to open up, hopefully, the questions. I don't know how to do that. I lied. If people have questions, they could just put it in the chat. Yeah. Yeah, so the question was about trending ammonia levels when we're caring for patients. And yeah, so you're right. So there's not a lot of evidence that shows the rate of change of ammonia is clinically significant at all. I think the number makes us feel a lot better. That being said, you're going to know way before the lab comes back whether your patient's getting better. So it's kind of just a common sense thing. Go look at your patient instead of ordering a test. But that being said, I think there is something to be said about the fact that if you show somebody came in with an ammonia of 250 and on day whatever they're now 50, that's a big change, and it makes you think about different things in terms of caring for your patient. Should you be trending it every day? Probably not. I don't think it's going to be super useful to you, but it might be something to think about, I guess. Yeah.
Small randomized controlled trials done in India, which was like triage, like stay, mortality, etc. And then, like on the slide, where was there something else done after that to show there was a this one was a small study.
So, quick question: was the study for cirrhotics or for acute liver failure? Okay, I didn't see that, so I don't know. Everything that I had seen kind of said, I actually can't even remember reading any studies that talked about it being useful. Interesting. Yeah, I don't know. I guess I'm going to turn the computer over to Dr. Lazar. Thanks, everyone. Because I couldn't get the mic to work, so I called in.
I have to use a different. All right, so now do I sign on to a different?
That's a good question.
Because the number is different, isn't it?
Oh, yes, I think I know how to do it. I think we can, we should have it open.
Oh, do you?
Launch Zoom meeting maybe? Just put back. We could just start that one.
All right. But I need to get my talk up here. Oh, the S drive on here?
Should be.
Can I keep you up?
Sure.
Do I need to?
Unless you can figure out how to get it to work from the computer.
Did you start recording?
No.